Good morning, everyone. Steph and I, Steph Squared, are going to be presenting this morning. And I'm going to be presenting a case that I saw with Dave 2 weeks ago. That was a great, very exciting case for me, at least. So I'm presenting a case of a 53-year-old woman. She has a past medical history of obesity and osteoarthritis. She presented to her regular doctor for a yearly physical. At that visit, there was documentation that they discussed that she should get a screening colonoscopy. She'd never had a colon before and had a lot of questions. There was concern on her end due to perceived invasiveness of the procedure. She didn't have somebody who could take her home. And so because of that, they proceeded with a Cologuard test instead of a colonoscopy. The Cologuard was positive, and so therefore she was subsequently referred to GI for a colonoscopy. Just moving this thing on the bottom, sorry. Okay, perfect. Oops. So this is the video. Thank you, Nick, by the way, for helping me get this to work last night. So we're doing the colonoscopy and we get to the splenic flexure, and this is what we find. This large area of nodular and some depressed mucosa. There were areas of friability and then we tried to biopsy. These are just 3 pictures of the area kind of showing that it was depressed in some areas and more raised up above. And again, this area extended really pretty extensively at the splenic flexure. We then proceeded to tattoo the adjacent wall. So you can see our tattoo here for future procedures, and we biopsied. So I thought I'd take a moment this morning. Many of us were talking about this case and how interesting it was and talking about what a laterally spreading tumor is and a little bit more information about it. So laterally spreading tumors are considered very important precursors of colorectal cancer. They're defined by the Paris Consensus as a lesion larger than 10 millimeters in width, and it needs to extend both laterally and circumferentially, and not just specifically vertically. You'll often see people discuss whether they're granular or non-granular, homogeneous or non-homogeneous, heterogeneous, and the appearance of the tumor. So we'll talk about that as well for when we see them on endoscopy so we can grade them appropriately. As we said, they spread laterally and very commonly do not invade into the submucosal layer, which makes an endoscopic resection actually the ideal treatment for these tumors and therefore don't need surgical intervention. So I thought this was a nice picture. We had actually pulled it up in endoscopy, but essentially brings up the 2 different kinds of laterally spreading tumors. Shows that there are the granular and the non-granular tumors, and they can be homogeneous in the way they appear, or they can be heterogeneous, flat and or actually depressed or elevated off of the surface. And these are some pictures we had found. Some other pictures just as more representative for everyone, granular tumors, and then this non-granular. So laterally spreading tumors, we often talk about endoscopic management, very commonly is EMR. I read that you can do an en bloc resection of lesions less than 2 centimeters, and you can also do piecemeal resections of larger lesions. Other papers had discussed using ESD for management of larger lesions, those with depressed morphology, or if there's any concern, of course, for submucosal invasion. So I found a systematic review with meta-analysis that was done in 2019, looking at how to manage these laterally spreading tumors. So this systematic review looked at 3 different databases and included a total of 49 studies. 27 of them specifically looked at laterally spreading tumors, and then 22 of them had as a subset. All of them are over 10 millimeters, but they did not break it down by the type, whether they were granular, homogeneous, heterogeneous, et cetera. They looked at the overall pooled successful resection rate, and that was 75.6%. And that was broken down then subsequently by EMR and ESD. And you can see there's pretty significant difference with EMR being 37% and ESD being 93%. And overall, it was considered a curative procedure in 90% of cases, which I thought was amazing. And the lowest cure rate was in one study that was only looking at lesions greater than 3 centimeters. In terms of adverse events, they looked at perforation rates, bleeding rates, both immediate and delayed. They found that the pooled perforation rate was 4%, but not surprisingly higher with ESD compared to EMR. And then the pooled bleeding rate was significantly higher in the EMR group and less in the ESD group. They looked at recurrence, and they found that it was not surprisingly higher with EMR compared to ESD, 5% of patients, but 87% of these were successfully treated on a second endoscopic procedure, so they did not need to go to the OR. And only 2% of the patients in the study actually who had undergone an endoscopic resection ultimately were referred for a surgical procedure. And the reasons for these included adverse events, recurrence, and then incomplete resection, which was the highest reason. I then found another paper that I thought was interesting out of Australia, looking at risk stratification for which of these laterally spreading tumors are highest risk for mucosal invasion. Because when we originally saw this tumor, our first concern was that there was a malignancy in this young woman. So this study out of 2017 and out of Australia looked basically at large sessile polyps and LST, so it wasn't specifically looking at laterally spreading tumors, but included over 2,000 laterally spreading tumors. They found submucosal invasive cancer in 7.6% of lesions. And these were kind of the criteria that were most highly associated with the development of a invasive malignancy, a Kudo pit pattern of 5, depressed component, which we had talked about a little bit, rectosigmoid lesion, specific Paris classification, and non-granular surface morphology. I liked this paper because they presented this graphic, which I thought was very helpful in showing at the top the homogeneous and the second row or the heterogeneous laterally spreading tumors, showing that actually the non-granular laterally spreading tumor was the highest risk for developing an invasive cancer. And interestingly, they broke them down whether or not they were proximal or distal, which I thought was interesting. And the granular homogeneous were the lowest risk. Those are ours. The bottoms are obviously not laterally. So back to our case, we biopsied the lesion. We took care, Dr. Green was very specific to make sure we did not biopsy the lateral edges so we didn't cause any scarring to help with future EMR. We tattooed the wall as I showed you, and path came back a tubulovillous adenoma. And she is planned for EMR ESD next week with Satish. So just in quick conclusion, laterally spreading tumors are these large lesions greater than 1 centimeter in width. They expand laterally and circumferentially along the colonic wall and not vertically. EMR and ESD are a much less invasive modality for treatment than sending the patients to the operating room. Highly effective, highly curative in majority of patients. If you see recurrence after the first endoscopic procedure, that second endoscopic intervention is often successful, and a fairly low rate of adverse events. Just remember, non-granular heterogeneous tumors are the most highly associated with underlying invasive malignancy, which is what our patient had. And yes, screening colonoscopies save lives. So thank you.
Great, that's a fantastic case and covered from A to Z there. You know, so Steph, if you were to attempt, you know, there is that, maybe go back to the picture of the original endoscopy. You know, so when you're assessing this, and we've talked about this, you know, a lot at this conference and grand rounds and other things. And, you know, the bottom line is, I think you guys made the smart decision that if you're going to do a polypectomy removal, you need to go in with the intent of completing it. You never want to do a partial polypectomy. You never want to do, you never want to start it if you don't think you can stop it. And the question comes up all the time, if you're doing a screening colon and see one of these, what should you do? And, you know, I think, I'm sure I could speak for Satish and Akil, is that, you know, when we get called in the room, one of you guys finds one of these things, or we find one of these on a screening colon, you know, I think our preference is to not tackle it right then and there. Personally, I book these cases for about 90 minutes. You need to take time. This is not like a, you know, 5-minute procedure. They don't always, they can certainly just take 20 minutes or so, but you want to really have all your equipment there, be ready to do things, and also counsel the patient pre-procedure about the potential risks and everything. So Steph, just point to the group where the smooth non-granular portion is.
There's appears to be smooth non-granular here, correct?
Yeah. And that's exactly right. And what's interesting about this is it's the granular portion. Maybe just point out the granular portion for everybody. It's the granular portion that always scares people.
Here, yeah.
Like the middle of that lesion. It's the granular portion that always scares people when we get these cases referred in. And interestingly, that's usually the most benign portion. The risk of invasive cancer in the granular portion is it's near zero. Fortunately, the smooth or non-granular lesions are less common. But Steph, if you guys were to attempt a resection, what kinds of things would make you stop as you were going? What features of the procedure or of the polyp would maybe give you pause about whether or not you should continue the resection?
I mean, if we were to have attempted it that day?
Yeah.
I think the depressed component certainly was concerning because that maybe needs a deeper resection. The fact that in this area, it did look somewhat depressed to us. They were both raised and depressed components. In terms of, I guess, just the size of it.
How about maneuver-wise? Is there anything, like if you injected it or tried to snare, is there anything that would give you concern?
If it didn't lift appropriately, you'd be concerned that there was mucosal invasion.
Or submucosal invasion.
Submucosal, sorry, yeah.
Right. So that's exactly right. So, and I think we all know this, the non-lifting sign. And you can get fooled out by the non-lifting sign if extensive biopsies are taken. And again, I think you guys did a perfect job of trying to minimize the risk. If you take too many biopsies, or sometimes, we get these referrals from the outside where it's my favorite line. They'll say, there's a 3.5 centimeter polyp, but don't worry, I took out half of it with a snare. That's like the worst thing in the world for us, because it just creates scar tissue, and you really can't tell if that's submucosal invasion from cancer or just fibrosis. And then the last thing is tattooing. You never want to tattoo inside the lesion. You always want to tattoo away from it, because again, that can cause a very severe fibrotic reaction and minimize your success. Or making it more, I shouldn't say minimize your success, just making it more difficult to resect it, but usually we can get around that.
Chris, can I just ask, was
Sure.
was there really any point in taking a biopsy at all? Couldn't you argue, no matter what, this had to come out, the biopsy?
I think if it came, I think if you took a biopsy of a very suspicious area and it came back cancer, I think you're done, and then the patient can just go right to surgery. I think that's the point of this, but
I see. Is there a possibility of biopsying and not finding cancer? And yes, it still is, of course.
Yes. Of course, yeah. And that's part of the counseling with the patient before an endoscopic resection is, we may tell them, and this happens not infrequently, we may completely resect the lesion, but if the pathology comes back showing invasive cancer, you're likely going to need surgery for a definitive oncologic resection. Again, meaning lymph node dissection.
Which is exactly what we did. We took like 2 biopsies of the most suspicious looking area, nowhere near anywhere where you were likely to be injecting underneath to resect it, and figured that we needed to come back and talk to her and set up an extended session to remove this.
And then just one last point I'll make before anyone else has any other thoughts is that, that those papers you quoted were from Michael Burke from Australia, and I would argue, and I think Jerry would argue as well, is the world's preeminent polypectomy expert these days. He has done amazing prospective randomized studies of thousands of patients looking at various techniques, comparing different techniques for endoscopic removal. And the bottom line, based on his studies and other expert opinion, is that for these lesions, EMR is the standard of care. It's proven to be safe, effective, and cost effective compared to ESD. ESD, on the other hand, really is the treatment of choice for patients who have a superficial cancer, like a T1A cancer, where you want to get an en bloc resection. So sometimes biopsy comes into that. Sometimes it depends on local expertise. I don't know if Nikhil's on. I'd be curious to hear what his approach would be looking at this, if he would go straight to ESD or if he would just do a standard EMR.
I would do a standard EMR. One of the things that I think was really important that Steph highlighted was, when we see these larger lesions, we kind of in our head are going through all of these checklists of things. So what's the pit pattern? What's the Paris classification? Is it granular? Is it non-granular? Because we're looking to differentiate higher risk features that would portend more of a diagnosis of malignancy, which would change our approach. But Chris is exactly right. With the majority of these lesions, if there's no superficial cancer, you can resect them quicker and safer and with equal effectiveness with EMR compared to ESD. The only real benefit to ESD is when you get into that superficial cancer and you need to ensure that you have negative lateral and vertical margins to ensure that you've been able to completely achieve an R0 resection. So, you know, the other thing when we do these cases is you don't have to get super aggressive with a big scenario. You can do it piecemeal and you know, just make sure that you're able to completely take down the polyp sort of piece by piece. It doesn't have to be in one big piece. And so there's oftentimes we'll do repeat injections to get submucosal lifts during these larger resections. They have newer commercially available injectates that we have in our endo unit for these types of lesions where you can have a sustained lift because that's really our safety margin to really get a good submucosal cushion, so we reduce the risk of things like perforation. And that's why we ask our referring docs to not extensively biopsy and to not tattoo under the lesion, because those will make our resection a lot more harder.
And to the point I was making earlier about taking the time. So yesterday, Yakira scoped with me, and we had on our schedule a patient for follow-up colonoscopy after we had removed a 2.5 centimeter cecal polyp about a year ago. His follow-up got delayed because of COVID, and his prep at the initial time was not great. When we went in yesterday, the cecal site looked pristine. We saw a nice scar, but on the way out, we found not one, but two laterally spreading tumors. One was 3 centimeters in size, one was 3.5 centimeters in size. And it completely delayed our entire day because we, you know, hadn't had it booked we hadn't planned on doing any more big EMRs. Shout out to Yakira for a fantastic job of removing the 3.5 centimeter lesion. But, you know, again, it's just part and parcel with what we do. And I think, you know, hopefully we save that guy a right hemicolectomy. So great. Awesome case. Thank you very much.
Thank you.
Great discussion. We'll turn it over to Stephanie Rutledge.
Okay. This is my Zoom debut, but can you see my screen?
Yes.
Yep.
Good. Okay, perfect. So my case is perfect. So I'm going to present today a case that we came across on service. It was a few months back with Maya Kayal. And it was the case of an 85-year-old lady with a pretty significant past cardiovascular history. She sort of had the whole shebang, a prior stroke, CAD with a prior MI, a DVT on Coumadin, chronic kidney disease, which was pretty advanced, hypertension and gout. So she presented to the ED with this diffuse, sharp, non-specific abdominal pain with no alleviating or exacerbating factors. She'd been having loose, blackish stools for the past week, and then on the day of presentation developed nausea and emesis, which is what prompted her to come to the emergency department. She had never had an EGD or colonoscopy because, in her own words, she was too scared, which sort of reminds me of the other Stephanie's patient who thought that they were too invasive. And I just think it's sad, and sort of, I know something our institution is working on a lot, but she's a very elderly Black woman who has never been screened for colon cancer, and she's reached the age of 85. And it just reminds me of patients' misconceptions about what a colonoscopy involves. And I guess in her case, well, I'll tell the story first. She had labs that were notable for a lactate of 5.5 on arrival, which improved to the 2s. Her hemoglobin, I think, was concentrated on arrival because it was 4.2, but then went down to 10 after some IV fluids. Her white count was impressive at 20, then 25.6 with 8% bands and a left shift. She had an INR of 2.4, therapeutic for her use of warfarin. So I examined her in the ED. I actually remember it vividly because of her rectal exam. So she wouldn't really allow me palpate her abdomen because she was very tender. She didn't have rebound or guarding, but was just extremely tender throughout. And then this is what I put in my note prior to the scope, but she had this bright red blood with pus, and it almost looked like currant jelly. I've never seen anything like it, and it was just oozing out onto the bed in the ED. So that is sort of imprinted in my mind now forever. But we saw her, and we decided to go to Flex Sig. We didn't want to do a CAT scan because of her renal function, but we were unsure what was going on, and this was what sort of the scary sight that greeted us as we sort of came up to the rectus sigmoid. So you can see in sort of the 6 o'clock to 8 o'clock range on your screen that there is just gray mucosa that looks nodular with like almost a purulent exudate over it. And then the mucosa in the remainder of the screen is erythematous, granular, it looks hemorrhagic. And to me, it seemed like the mucosa in the gray segment looks like dead mucosa to me. It looked like it was pretty horrifying. It looked like it was no longer living. We didn't know what this was. I think we called Satish into the room, as is typical, to find one of the advanced endoscopy attendees and ask them what they think. And we wondered, was it like the single stripe sign from ischemic colitis? And then we decided at that point to get her a CAT scan because we'd been holding off giving her creatinine, but at this point we were concerned about her mucosa. Here's just some stills. So you see this horrible, disgusting looking mucosa up here. And then these are just our biopsy sites, but the mucosa normalizes as you come out of the sigmoid and up to the descending colon, up to the splenic flexure. So we were very worried about ischemia. And so we did decide to go ahead and get a CAT scan same day. And it showed diffuse colonic wall thickening. So you see here, the contrast is in the lumen, and that's only a little segment of lumen. The rest of it is very thick wall. Here in the rectum, the same, and then another segment over here. So the read, however, from radiology was that this was the marked diffuse wall thickening and throughout the colon argued against ischemic etiology, which was interesting because we didn't go all the way to the cecum, but the mucosa looked like it normalized beyond the sigmoid. So the pathology came back showing mildly active colitis and marked acute inflammation in the colon and the rectum. And they also felt that infection could not be ruled out, which was unexpected. When we got this back, we spoke to the team and they checked C. diff and GI-PCR, and both were negative. And at that point, she was having no diarrhea. To give you follow-up, she's actually done very well through COVID and she's at home having no GI symptoms and being seen by the visiting doctors every few months. And she has done fine. She's never come back to GI clinic or had a repeat colonoscopy, but I think she's made a full recovery. So I actually would argue that I don't think she needs a repeat colonoscopy. Just a quick overview of, I'm going to continue to present on ischemic colitis, even though we were told that it wasn't. I do think that given how tachycardic, chemoconcentrated she was coming in with currant red jelly, the black appearance, I still believe it was ischemic colitis, even if the pathology and the radiology don't exactly fit. The etiology is decreased perfusion to the colon, and there can be two types. One is just mucosal injury, and the other is full thickness necrosis with gangrene, which is a much worse outcome. The incidence is 4 to 44 per 100,000 person years, and patients can present with these self-limiting vague abdominal symptoms, which was definitely her, very non-specific with the black stool, the nausea, the pain, but the risk factors are age over 65, we believe female gender, constipation, systemic arterial disease. So she had 3 of those. And most cases are transient and resolved with conservative management. And there's a real spectrum. There are patients who just have a little bit of bleeding after they didn't feel well for a day or two and who do fine. And I think the voluntary faculty have told us about those patients that they see in the office who recover after one day. And I think we see the other end of the spectrum in the hospital as fellows. These are the areas that are most commonly involved. So they're the watershed areas where at the anastomosis of these branches, and they're highlighted here up at down at the rectus sigmoid and up at the splenic flexure. So they're the most likely to be affected. And ischemic colitis is most of the time is a low flow state. So it's not that they've thrown off a thrombus, it's that you're overall not perfusing well enough, and the distal parts of those arteries are not getting enough blood flow. The question that I have, because it comes up all the time, and we hear different things depending on who we're on service with, and I just think it's really interesting. Do we need to do a colonoscopy when the story fits with ischemic colitis? So maybe in this lady's case, maybe we needed to because it wasn't so clear and we couldn't get imaging. But currently the ACG does recommend that we do an early colonoscopy within 48 hours to confirm the diagnosis. And I've heard people argue either way. The evidence out there, a study by Dr. Brandt, is that colonoscopy helps you determine what part of the colon is involved by ischemia, which helps to predict helps to risk stratify and prognosticate. We know that ischemic colitis isolated to the right side is worse than colitis anywhere else. So they are the reasons we do it. The other reason we do it, and the guidelines are based on this one trial out of Spain, where there were 364 patients were prospectively enrolled from this big hospital system that served 3.5 million people. They were patients with ischemic colitis who a GI doctor identified through looking at colonoscopies or the GI or surgical census from the day. It was a little bit of a self-fulfilling prophecy in that some of the patients were found through their colonoscopy findings, which showed ischemic colitis. So the majority of them, nearly all, had a colonoscopy, 345. So they were looking at outcomes, and they showed abdominal pain without rectal bleeding predicts poor outcome, non-bloody diarrhea, peritoneal signs, or isolated right colonic ischemia. And 12.9% of patients had an unfavorable outcome, either mortality, which was 7%, or needing surgery. Their argument is that if we find isolated right colonic ischemia, that's much more likely to need surgery. So that's someone that we would then be more concerned about. You might be able to see that on imaging, but I think less often. The other reason is that these are the findings that were found in that study. Erythema, edema, and friability, as well as superficial ulcerations, being the most common. And then there's this less common blue-black nodules with a dark dusky background, and that suggests gangrene, which does require surgery. And this is the image included in the paper below. Which I don't think our patients find colonoscopy looked exactly like this one. Their rationale is that the sooner you do the colonoscopy, the more likely you are to find those hemorrhagic nodules. And you can see that the more days from colonoscopy, the lower likelihood of finding this hallmark of gangrene. So I don't know, I'm still not convinced. I think that if the patient is elderly, peritoneal signs, rising lactate, I mean, then I think that is an indication to go to surgery. And I think if we're worried about them, it's great to have surgery on board to monitor their exam and let us know what they think. But my feeling is that all ischemic colitis should probably not be going for colonoscopy within 48 hours, although they showed no adverse outcomes because no increased adverse outcomes. They minimized the insufflation of air. I'm still not sure that it's necessary unless there's many risk factors or something that's making you really concerned about a poor outcome or full thickness necrosis suggestive of gangrene. Then I don't think that we should be, but I would love to open up the floor to those who are more experienced and hear your opinions.
So great presentation, very interesting case. I'm in the camp that these patients don't need colonoscopy. I think in a lot of patients, this patient might have needed one. I mean, because if you got the CT, you would have seen pancolitis, which, you know, it occurs about 5% of the time in ischemic colitis patients. So it's not classic, but we all know 5% is a real number. Just ask any ERCPist who gets post-ERCP pancreatitis. And so 5% of ischemia patients have pancolitis. Okay, you're going to see that, and you're going to see that more than once in your career. So in this patient, I think they would have probably gotten to Flexig at some point if you CT'd first and then Flexig later, because pancolitis didn't make a lot of sense. But I'm generally in the camp that it's a fairly clinical diagnosis. Most of these patients have typical risk factors, typical symptoms, and a scan will often show colitis in a consistent area. The decision to go for surgery is not an endoscopic one. You can see mucosal ischemia, even mucosal necrosis, but the reason to go to surgery is transmural disease. And unless someone has a colonoscopic finding that has a high predictive value for transmural disease, I don't think there's a reason to be scoping all these patients.
I'm going to throw a scenario out there. I think Dr. Steinhagen is on, so maybe he can comment, and certainly Stephanie, if your research in this has come up with an answer. When I was a GI fellow, not at Mount Sinai, we had a patient, this similar case, and the surgeons were pretty adamant that we do a flex sig, and they were in the room when we did it, and they specifically wanted us to take a biopsy with the logic that if there was no bleeding on the biopsy, this patient had a necrotic bowel and needed emergency surgery. I don't know if Dr. Steinhagen can comment.
I don't know. To be honest with you, I've never heard that specifically. Obviously, we're actually more concerned about what's going on the outside of the bowel than what's on the inside, on the outer wall, let's say, than the inner wall. There was a time Barry Sauke was doing laparoscopy in the ICU to look at the serosa of these loops of bowel to try to determine if there was full thickness ischemia. And I think he was happy with it at the time. Bleeding on a biopsy, quite honestly, I've never heard that as a criteria for determining anything. I think more likely it's the clinical presentation, how much tenderness the patient is having, peritoneal signs that are going to make me decide one way or the other.
Yeah, I'd agree with that too. You know, that there's a lot of ischemic colitis where I see everybody getting lactates. I'm in Satish's camp. I don't think most of these people need colonoscopies. But what I do see a lot, which I would try to discourage, is this sort of use of like multiple lactates over time. And once the person has a very high lactate, you know, they are probably developing necrosis and gangrene. But everybody else who's you know, sort of mild doesn't need these serial lactates, I think.
I certainly agree with that. I think lactate is a function of so many other things related to hydration status and liver function that it isn't really that, it isn't specific enough to give you any real information.
Great presentation, Steph. Quick question. To what extent does a CTA really help with the diagnosis here? I know oftentimes we might subsequently get a CTA. How often does that help clarify what the etiology is in a case like this?
Yeah, so I think it often does help when you have the right clinical setting, and all you just need to see is that watershed area described on the CT, and you sort of, I think then you're done. The reason to do a CTA, to my knowledge, is you're looking for mesenteric ischemia. So you're looking for a thrombus, which is rarer, but typically causes more right-sided colitis. And that's something that, at least my practice has been, that if we're maybe just checking the lactate just once, Dave, I promise,
okay,
if the lactate is elevated or the exam is concerning, to get a CTA to make sure that there's no thrombus that requires a thrombectomy. And I always think it's nice, because if you're like, I think it's ischemic colitis, but if we're not going to scope them, I'd love confirmation. But I'd love to hear what others are doing in practice.
The CTA is going to be normal in typical ischemic colitis. The only time really to be doing that is when there's isolated right colon ischemia, because then you're looking for disease in the SMA distribution. By the time you see the patient, in the vast majority of people with ischemic colitis, their blood flows back to normal. The mucosal damage happened previously, it's going to get better, and all of the vascular studies would be normal. So I'd sort of discourage it unless there's right colon ischemia.
And if you didn't have a colonoscopy, so you didn't know that there was right colon ischemia, would there be anything that would push you to get a CTA?
So remember, the CTA, you know, you get an arterial phase contrast, which shows you if there is occlusion within the vessel. Now, most colonic ischemia, even right-sided colonic ischemia, is not vascular occlusion. It's all still low flow. Now, what a regular CT can tell you, and I'm curious to see what this lady's CT is, you can actually look at the origin of the SMA off the aorta, and you can see if there's a lot of calcifications. And that'll give you a clue to what degree of vascular disease. You'll find most of these patients have calcifications at the takeoff of their mesenteric arteries. Even in isolated right-sided colonic ischemia, it's still usually low flow, but it's low flow at the distal SMA. And so what it does is it portends bad SMA disease, which is a bad thing. But even still, when you have right-sided colonic ischemia, it's still low flow, which is low flow in a dangerous spot. So the CTA generally is not necessary because that's only for vascular occlusion. So if you have small bowel disease, small bowel ischemia, then that's from thrombus. And that's where the CTA is really good.
Yeah, just a couple. One point about that. Yeah, I had a patient who I was seeing in clinic who had actually admission since like 2017, mostly actually just in the ER, where she'd come in with abdominal pain, and then they would do a CT scan. There was thickening in the right side. She'd had a colonoscopy once or twice, which was consistent with right-sided ischemia, but no one worked it up further. And she was a clear vascular path, end-stage renal disease, the whole deal. And she also had symptoms of chronic mesenteric ischemia, like afraid of eating food, and pain after eating. And so we sent her for CTA, which showed pretty severe disease in the SMA and celiac, and she ended up getting stented and hasn't had any recurrent emissions at this point. So I think definitely to keep, like, not necessarily on the inpatient setting, but for long-term management, if people keep on having right-sided ischemia, to think about that.
Yeah.
What you're really saying is that
that's interesting. I guess
what you're really saying is that the CTA is useful if you suspect a thrombosis or an embolus rather than just low flow. But in the absence of that, I don't think the CTA is that useful.
Exactly.
Yeah, I guess my question is, how do you, like, does anyone have, like, is there a hallmark for more likely small bowel disease? I guess more melena, pain, lactate, because sometimes it's hard to differentiate, and I'd like to avoid imaging if possible.
That's going to be your typical pain out of proportion, and also patients who have embolic risk. So the AFib patients, some of the young people on OCPs, that kind of thing. You don't typically have sort of diarrhea melena per se because it's so high up in the small bowel. But it's risk factors and that sort of typical story or exam, I think.
Okay, thank you.
From my perspective, when you see this woman, elderly, multiple risk factors, coming in with acute onset pain followed by blood and a white count of 20, if ischemia should be on the #1 thing that you're thinking about for this patient, maybe, with a lactate and exquisite tendon, did she perf? So even with renal insufficiency, the first thing I would have done is I would have sent a CT scan on this patient as opposed to doing a flexig. And the other comment is, just because you saw that rectal involvement, that does not mean that it's not ischemia. You can absolutely have rectal involvement when you have ischemic colitis, and something you're sort of taught in med school, maybe in residency. Oh, it's usually involving these washer. No, it can involve any part of the colon, including the rectum. So don't be fooled when you see that on the flexig.
But it often doesn't involve the rectum. I mean, it's often an isolated area in the sigmoid or splenic flexure.
Yeah, I think rectal involvement is the exception rather than the rule. The blood supply is completely different.
Yeah, it's in that small category of a few percent, just like pancreatitis. So it's there, but not your classic for sure.
This is a great case, Steph, because it's got all these atypical features that allow us to discuss all this. So nice work.
Yeah, no, and great discussion. I think very, very useful discussion for sure.